Hello, I'm Dr. Annalene Weston, dental legal consultant at Dental Protection. Welcome to Risk Matters, our latest series of podcasts created specifically for dental practitioners. As this name suggests, Risk Matters is all about managing risk. And in this podcast series, we're going to be taking your feedback and queries and putting them to leading industry experts, getting them to answer the difficult questions about managing risk and working safely. Because it's all about what to do when managing risk matters most. So today we're going to be talking about essentially doing a deep dive into body dysmorphic disorder. And I'm absolutely thrilled to be joined by my friend, specialist prosthodontist, Dr. Carolina Perez Rodriguez. So, Carolina, hello.
Hello, how are you? Lovely
Yeah,
to see
brilliant.
you. Lovely to be here.
Yeah, I'm so glad you're here. I'm just going to start off by reading your bio. Carolina graduated from
Complutense.
Complutense University of Madrid in 2006. And she moved shortly after to the UK, where she worked in both public and private settings and gained membership of the joint dental faculties of the Royal College of Surgeons. In 2013, she moved to Australia, and while working in private practice, she undertook a postgraduate diploma in dental implants at the University of Melbourne. She also completed her prosthodontic specialist training at the University of Melbourne and was awarded the Straumann Group Award for Academic Achievement. So Carolina works in a private specialist practice in Moonee Ponds and Glen Waverley. She's a lecturer in prosthodontics, at the University of Melbourne. She's an ITI fellow and a member of the International College of Prosthodontists, Prosthodontic Society, and the Australian Society of Osseointegration. And there she is. Okay, thanks, Carolina. So I've been quite lucky to hear you talk about this subject before because it's something that we are going to put in the episode notes. There's actually a paper that you wrote about this, co-wrote about this. So it's something that you have more knowledge and understanding about. And of course, it's something that's quite a hot topic in Australia at the moment with the ARPRA guidance. So
Yes.
I guess for our listeners and viewers, the first question I wanted to ask is if you could please start off by defining body dysmorphic disorder for us, give us like a broad brush of how this is showing up specifically in dentistry or in dentofacial aesthetics.
Um, so, body dysmorphic disorder or body dysmorphia is a psychiatric condition. It is described in the Diagnostic and Statistical Manual of Mental Disorders, which is published by the American Psychiatric Association. And is characterized by an excessive preoccupation with a slight or imagined defect with some aspect of the physical appearance. So patients with or people with body dysmorphia, they tend to think about their perceived flaws, real, small, for hours each day. And they have uh, a real concern that is very disproportionate with the flow itself or with the perceived defect. I think it's important to understand that most people will have some concerns about their physical appearance, but they don't have body dysmorphia. We live in society in a world at the moment that puts a lot of emphasis in physical appearance. It is a multi-billion cosmetic treatments are a multi-billion industry. But for most people, you have a perceived concern. You're worried about something in your physical appearance, but it doesn't really impair your day-to-day life. You can function pretty normally. You can go to school or to work. You enjoy friends. You enjoy social interaction. And for people with body dysmorphia, this really impairs their daily functioning and their social interactions.
So that's a really helpful definition. So the difference then I think becomes perhaps obvious about the difference between a normal cosmetic concern and clinical body dysmorphia. It's that the hours of the day, isn't it? And it really impacting on your life and how you live your life. That would be the definer, wouldn't it?
Yeah, so the key word is disproportionate. So there is a disproportion between the concern itself, between the physical flaw and the worrying that these people experience. So they tend to have a lot of repetitive behaviors like mirror checking and adjusting hair, adjusting clothes, concealment, makeup, photos on this angle or that angle. Um, and this really gives them a lot of social anxiety, social phobia. They tend not to go out or to worry so much about people judging them. They feel real shame. Um, and some of them is so severe that they even have suicidal thoughts. So it's something that is really disproportionate and that it really impairs the daily lives and their social interactions.
No, it's really sad. Really, really sad.
It is.
So, what are the common features dentally then that are there some common features that patients would fixate on that others wouldn't notice? So I'm presuming like as a prosthodontist, practitioners are, or patients are going to come to your practice with cosmetic concerns as well. Is there like a pattern of the things that they worry about the most, or can it just be anything?
Look, unfortunately, even though this topic is very well documented and pretty well researched in the medical literature, there's still a little bit of a gap of knowledge in dental settings. So there are a handful of the studies, mainly in orthodontics and
Okay.
facial surgery or orthodontic surgery and things like that. When we published at the University of Melbourne in 2018, I think there were it was pretty much the very first study of that kind. And there's not a lot about restorative dentistry, cosmetic dentistry. So it is under research in that aspect. So we don't really know very well. But in my experience, it could be really anything. I have had patients worrying about one corner of a tooth not being the same as the other one. It could be gingival architecture. It could be things being slightly asymmetrical. Um, and of course, as I said, in orthodontics and orthognatic surgery, there is a lot more investigation. It could be sort of facial features as well. Um, so yeah, there's a broad range of things out there.
We've certainly had cases with dental protection where the patient has been unhappy and to all objective measures, they have an absolutely beautiful result. But when you look at their teeth, they can see something with a corner of a tooth. It's interesting you mentioned that. And it's so slight that you wouldn't even notice, even when they draw attention to it, like you really have to scrutinize to see. But for this person, it is everything to them. And it's this flaw, this error almost in the treatment they feel.
And it's very interesting what you said as well, because I think that you hit the nail on the head. Because the technical outcome might be beautiful. There might be really well done restorations. So, from a technical point of view, the treatment may have been executed very well. And it's more about the patient selection. Um, the key characteristic about these people as well is that you're not going to make them happy with treatment because it's really not about the physical appearance, it's a psychological condition. So, a lot of these patients would either they will receive treatment and they will still be dissatisfied. In some instances, they even might get worse, or they might shift the flow to another part, or worry about the same thing in a slightly different way. So when we're talking about corners or lines or angles or things like that. So really treating them doesn't really help them, and in
No.
situations can make things worse.
Yeah, we certainly have seen that. So, as a clinician, then, are there any patterns for body dysmorphia presentation that people could easily look for? So, for example, is it a particular age group or a particular gender, or is it something that it could be really any patient that walks in?
Look, in our research at Melbourne University, and certainly from everything that I have read in the literature, there doesn't seem to be a difference between um, genders. Actually, in our study, there was more female patients than male. But if you read the broad literature, medical and dental, there's not really difference in gender. the onset of body dysmorphia tends to be in early adulthood or teenagerhood. But the presentation tends to be around the 30s, 40s, something like that. That's for
Okay.
age and gender. But things to look out for or red flags would be persistent negative thoughts about appearance, again, excessive self-criticism, high levels of anxiety. Body dysmorphia has a lot of comorbidities with depression, with anxiety. It has a lot of things in common with OCD. Their belief that their appearance determines self-worth. And on the same token, seeking the approval of others, but then not believing when people are telling them that they look fine or that, that defect is not as bad as they think. So they discard that information. And then, as I said, depression, irritability, constant comparing with others. Yeah.
Okay. So one of the reasons that we're talking about this today is because of the recent ARPRA position, and I'm going to come to that in a moment. And I
Mhm.
had a question here to ask then about warning signs that a patient might be experiencing like body dysmorphia. But from listening to what you're saying, it sounds like if we take the time to really get to know our patient before diving into treatment, particularly treatment that's irreversible in nature, we're going to start to recognize some patterns of behavior in the way that they talk. Like I remember seeing, because I know we've talked about this before, but I only see stuff when it goes wrong. People don't ring up and go, "Hey, Annalene, something amazing happened. I did this treatment, everything went well, and the patient's really happy." Generally, it's when everything's fallen apart. And I remember seeing this particular matter, and on the consent form, where they were talking about, so it wasn't a consent form, it was a patient information collection form. All
Mhm.
the way through it, they'd written some stuff about my smile is ugly. I am ugly. And they were
Mhm.
using some really quite strong words. There was some swearing
Mhm.
on there. I would do
Mhm.
anything not to be. And the practitioner proceeded and did a series of cosmetic treatments. And of course, none of them changed the way that the patient felt. But when you wound it right back, just in that early patient information gathering, the signs were all there in what the patient was declaring. The practitioner hadn't even asked any questions. They'd given the patient a form. And even on that form, it was apparent that this patient was very, very unhappy with their appearance. There were some red flags firing off there. But would you agree a conversation would be quite important at identifying this, wouldn't it?
Oh, look, everything, and we'll talk about this in a minute, but this is not something that it gets detected with a 5-question questionnaire. Obviously, you have a physical examination, you have your anamnesis, you have a questionnaire, but then you really need to have a conversation with the patient about their motivations and about their broader life. I found patients, and not specifically for body dysmorphia, but psychologically um, troubled or with some psychological stressors at the time. And they seek treatment, but they also sometimes have issues in their personal lives. So
Yes.
like very high stressors, maybe they're going through divorce or someone is really sick and they're caring for them. Or and you see that a lot. And I don't think that might be at least complex, comprehensive, irreversible treatment. That's probably not the right time in their lives to seek that kind of
No.
treatment. Um, and you're not going to find that in a questionnaire. You actually need to sit down and have a conversation. Yes.
No, you do. Now we're going to move on to the questionnaire thing now. So, um, so the recent APRA guidance on non-surgical cosmetic procedures says the following, and I'm going to read this out because I know that a number of colleagues are all over this guidance. They've gone through it with a fine-tooth comb. There's bits they like, there's bits they hate, where there's others who'll be listening to this going, there's APRA guidance. So the September 2025 APRA guidance on higher risk non-surgical cosmetic procedures. Now, that's the first thing that causes confusion, Carolina, because we consider dentistry to be a surgical procedure because we're cutting tooth tissue. But when the dental board, when AHPRA split this, they were referring to like physical cutting. Think boob jobs would be the surgical, and then dentistry fell into the non-surgical. And I know that that's caused a lot of confusion because obviously with veneers, we're physically cutting teeth. Okay, but it says the following. Registered health practitioners have a responsibility to ensure an evidence-based, holistic assessment of the person is undertaken. So it's our responsibility. The assessment should consider the person's history, relevant psychological, social, and cultural aspects, and in particular assess for any condition, including underlying psychological conditions such as body dysmorphic disorder, which may make them an unsuitable candidate for the procedure. Now, that's on the one hand, that is a lot of onus on the clinician, okay? Because we are not in a position to make an assessment whether somebody has body dysmorphic disorder. That falls outside of our scope of diagnosis.
Right.
So AHPRA put this statement out but they haven't given any further guidance on how we as dental practitioners could or should be doing this. So a number of colleagues have been contacting us at Dental Protection saying, is there an assessment tool? And can we recommend something? So I had a look on the medical board, because obviously the surgical cosmetic procedures is older guidance. And on the medical board, it says, we're not giving you an assessment tool. You've got to work out which one's the best. So I'm curious to know, in my head as a prosthodontist, you have people come in and they say, I want 20 veneers, or I want this smile like Julia Roberts, or whatever it is people say these days. How are you assessing them to ensure that you're considering their history, psychological, social, cultural, body dysmorphic disorder? How do you do it, Carolina? Have you got a system?
I do have a system, yes.
Phew! Well, that was going to be the world's worst question.
Look, I think it's very important what you said. We're not psychologists. To assess psychological issues from our patients is outside of our scope. But there has to be something, right? And of course, I am going to take for granted that we have done a physical examination, that we have discussed with the patient what they want, and that we have taken appropriate tests and things like that, including radiographs, etc. But essentially, I'm using the same questionnaire that I did in my research, the Dysmorphic Concern Questionnaire. I like it because it's very short. It's 1 or 2 minutes. The patient just answers the questionnaire. And it doesn't assess, or it doesn't give you a diagnosis of body dysmorphia, because I cannot provide that diagnosis. Right. I'm not a psychologist. But it gives you a rating of the dysmorphic concern. In other words, it tells you, well, this patient has a lot of symptoms of body dysmorphia without diagnosing that. I know that there are a lot of other tools out there. This particularly is being validated in the literature. We validated it in the dental literature, but it's also been validated in the medical literature. I work with the psychiatrists. When we did this study, I worked with the head of psychiatry at St. Vincent's Hospital in Melbourne. So it's short, it's been validated. It takes 1 or 2 minutes. It assesses symptoms rather than giving you a diagnosis. But then I also top it up with a few questions. So I have one here.
Lovely. Love that for us.
And what you need to take is a little bit of the history of the concern. So what prompted you to consider this treatment? Is that something that is coming from you, or is that something that is being driven by someone else? Why now? What has prompted you to want to have this treatment? So is it something that you've been thinking for a long time, or is it because your ex-partners left you, or you're hoping to get a better job? So it sort of talks about the motivations for treatment. Has anyone influenced in your decision and encouraged you? Some people, it's very funny because they they answer, just my general dentist refer me here, which is fair enough. um, what are you hoping to achieve with this treatment? So are you happy? Are you being concrete about what this is going to give you? Or you thinking that you're going to get psychological benefits, which I cannot promise? Um, and how are you hoping to feel or look after the treatment?
It's an
So,
interesting one.
sorry?
That's an interesting one. How are you hoping to feel or look? That's a really, yeah.
Yes.
Okay.
So, um, yeah, apart from the questionnaire, which is the dysmorphic concern questionnaire, I asked a series of questions. And then if I feel that, some of the questions are, I can follow up with further questions about their personal life, about their emotional life, and things like that. There are other, at the moment, there are applications out there. One that is led by a psychologist here in Melbourne. And I know that a few maxillofacial surgeons use these. Um, and my husband, Liam, I have been using him as a guinea pig, and I have made him sort of fill in several questionnaires. And for him, one of the feedback that he gave me is that this feels fairly okay for a dental practice. Some of the other questionnaires that are out there, they are much more medical or psychological. And he sort of said, I'm not sure that I want to answer all of these questions in a dental.
Okay.
So
That's
that was
good. Cool,
interesting
Liam.
feedback.
I experiment on Matt and the kids all the time. I have to say, it's hilarious. I always say every time I do communication training, I get statistically significantly harder to argue with. Matt
Yeah.
hates it every time, every time. But anyway, where does one find the dysmorphic concern questionnaire? We just Google it, or does it belong to someone?
Well, if you want to, if you have access to my research, the
Mm,
article that we publish, it is there. Um, yeah, I'm pretty sure
okay.
that
Yeah, I'm
we
going to
can
put
find.
that. Yeah, I'm going to put that in the episode notes for people.
Right.
Okay. So the other thing I'm really curious about, and it's starting to come up as a pattern, not just of questions, but also in the complaints that we're seeing. Patient comes in and they want, I'm going to use veneers as an example because we're
Mhm.
noticing there's a big drive towards veneers, more so than we've seen in a long time. It's all over Instagram. Patients seem to know what they are and they seem to be they're asking for them, right? They're asking for them. So, patient comes in to me, says they want veneers. I want veneers, Annalene. I feel that in many ways I should be putting every patient through the same process. Because what worries me is if I don't, we're going to start seeing complaints about discrimination. Pa- Patients saying, well, why me? Why did I have to do that? So if it's your standard practice process, do you see what I mean?
Yes, this is my standard patient process for every single patient that
Yeah.
comes new to practice, not for only those seeking cosmetic treatment.
Yeah. So that's our thing that we do. Okay. So then, when and how are you as a dental practitioner, specialist as you are, of course, general dentist as I am, when and how are you going to refer a patient to a mental health professional? Is it something that you do? Is it something that you do off the back of this tool? Or does everyone have to go? Like, what's your process and what do you think or feel is reasonable?
So I have recommended, yes. So when I have had a patient and we have done all the assessment and again, utilizing all the tools, not all the tools, not only that questionnaire, and I have serious concerns that the patient might have a degree of body dysmorphia, or in a broader sense, if I feel that I'm not going to be able to meet their expectations, um, I sort of very directly say some. I would say, look, I don't think that I'm going to be able to meet your expectations. And I don't think that is in your best interest to have this treatment. So that's one thing. In terms of discussing a referral, and not only for body dysmorphia, I have had patients that have come with very, very, very high levels of anxiety. And I sort of discuss, look, I think it's important, first of all, to validate the feeling that they have, the stress and the anxiety that derives from their concerns. But you don't necessarily need to agree with it, and you don't necessarily need to treat them. And sometimes I've sort of recommended, I can see how this is making you very anxious. This is making you very stressed and how it's affecting your life. I think it might be a good idea to get a referral from a psychologist or even to your medical practitioner to help you with those aspects because I cannot. Um, Full disclaimer, no one has taken so far that offer. Usually patients will go somewhere else.
No, that's fair enough. So you get the GP to organise the referral. That's smart, because I think sometimes it's a scope of practice thing again. Don't ask questions that you're not qualified to manage the answer to. So a classic example is when patients have a needle stick. If you refer that patient for bloodborne virus testing and that patient has a bloodborne virus, you're the person with the results. Are you qualified to discuss that and what it means in future treatment with the patient? You're probably not. I think we can safely say. So you're often best off referring back to the GP to manage that aspect, because they are appropriately trained and qualified to manage that patient's questions and put them in the right direction. So you mentioned something about people going elsewhere. So I think we would both agree that not every patient should receive the treatment that they're requesting. Now, for me, this is super easy because I just refer, right? I'm a general dentist. I say, I don't think I can meet your expectations. Please go see Carolina. No, but do you know what I mean? Like general dentists, we have that position. But as a specialist, when you're sat at the top of the totem pole, it's harder, I think, to move people along. But also, we need to have a conversation with the patient about things not being in their best interest. So patients have the right to make decisions about their own body. That's, of course, called autonomy. But just because they want it, it doesn't mean that they're going to get it. And it doesn't mean that they're going to get it from you. How do you have that conversation? Because like I say, as a general dentist, I just say, this is too hard for me. How do you have that conversation?
So the question about autonomy is so interesting, because I'll just talk a little bit about autonomy first, and non-maleficence and do no harm, because they're interrelated.
These are like my favorite subjects.
Me too. Because we are nerds.
We are nerds. That's right.
That's right.
#nerds. Love that for us.
So I think it's important to understand that autonomy assumes that the patient is able to make an informed, rational, and voluntary decision about their care that is based on realistic expectations, right? So if particularly for a person that has some psychological distress or have some distorted beliefs about their physical appearance, that capacity might be temporarily compromised. So in those cases, simply agreeing with the request of treatment might look like you're respecting patients' autonomy, but can actually cause harm in the long term. And we have discussed about how, these patients, they don't tend to get better, they tend to get worse, or they sort of the focus shifts to something else. So respecting autonomy doesn't mean to comply with every patient request or wish. It means supporting authentic decision making. I have a mentor, you know him.
I certainly do.
Who used to say that just because the patient consents to the wrong treatment doesn't make it the right treatment.
It's very true.
It's very true, right? So do no harm is just not avoiding only physical harm, it's also psychological injury. If an intervention is likely to reinforce those maladaptive or wrong beliefs or worsen the preoccupation or create more stress in the long term or escalate the worry, providing the treatment will violate the do no harm principle of care. And on the other hand, as well, I think it's very important to remember that medicine and also dentistry, they're not a purely consumer-driven model. Clinicians are obligated to recommend treatments that are indicated, that are proportionate, and I'll talk about proportionate again, and that are likely to benefit the patient, and refuse anything that can carry an unacceptable risk or harm, whether it's physical or psychological.
No, yeah, proportionate. Love that. So we're talking about these realistic outcomes, that patients, the outcome has to be realistic. How do you think dental practitioners can communicate these realistic outcomes without discouraging patients? Because I know that I have this conversation a lot with young dentists. So when we're talking about the conversation of consent, which is what we are talking about at the moment, really, and when we're using terms like autonomy and proportionate, and that's what we're actually talking about, really. So we see this with young practitioners, and I mean this in the nicest way. They worry that if they go through all the risks and warnings, that the patient's not going to have treatment and not going to have treatment with them. So, for example, even something as simple as a fractured file. They worry that if they tell the patient a file can fracture and the root canal treatment will fail, that the patient won't have the treatment or will go somewhere else, and then they're going to get in trouble with their boss. And they can get themselves really quite caught up on this, or they're worried that the patient's going to give them a really emotional, negative response that they don't feel equipped to prepare, like they're not, ill-equipped to manage. So how do you think we as clinicians can communicate realistic expectations without discouraging patients from treatment altogether? Bearing in mind, of course, there are a percentage that we do want to discourage. I mean, the ones that,
That was going to be my first comment. There's a percentage that we would.
I could see it all over your face. You were like, except for the ones that we really want to discuss. The other ones, the ones that we don't want to discuss.
So, look, avoiding no harm or injury or problems to the patients sometimes requires tolerating a short-term dissatisfaction from that patient. I was having this conversation with an endodontist friend of mine recently, and she was telling me that after reading and discussing with the patient all the risk and complications of root canal treatment, the patient said, well, I do not consent to any of those. And then she said, well, we're finished here. Then you're not consenting to the treatment. You're not consenting to it. You have to consent with the good and the bad. Okay, so for me, ethical cosmetic dentistry starts with obviously listening, and we've spoken about that. But before talking about treatments, I need to try to understand why the patient wants change and what they're hoping to achieve emotionally. I want the patient to be very granular. So a lot of times when a patient says, I want a nicer smile, my very first question following that up is, what does a nicer smile mean to you?
Absolutely. Nicer
Because
than what?
exactly,
And
because
how much nicer? Just a bit.
you just exactly.
Can we just whiten your teeth? Like, wouldn't that be great?
That's right. So what we know, we're professionals, so we have a very good idea what a good smile or a beautiful smile looks like. We know about width to height ratios. We know about gingival architecture. We know about all of those things. And I think it's a little bit dangerous to assume what the patient might or might not want. So again, I want them to be very granular about what specifically they want to change. And for me, it's a little bit of not a red flag, but I always want to know more when a patient tells you something, a very broad blank statement, but they don't really know what is it that they are concerned about. Or just make it better, make it nicer. And it's like, well, what does nice mean? So what did you ask me again?
How are we going to communicate realistic outcomes without discouraging patients?
Oh, yeah.
Like honest, open conversations, I guess, is what we're saying.
Yeah. So after all of that, I'm very honest about what dentistry can and cannot achieve. I frame it around proportions, about harmony, and about health rather than perfection. I use photographs, I use mock-ups, I use wax-ups um, to show realistic ranges of outcomes, and I have shown patients some outcomes and see if that's what in line what they're thinking about. And after all of that, I am very transparent about limitations, and I never
Good.
used emotional language. I would never say,
Helpful.
you will feel so much more confident, or you're going to feel great and so happy when we finish treatment, because I don't know if that is true.
You have no idea how they're going to feel. No, that's really helpful. It's funny, patients can't always articulate what they want, but one thing I will tell you as the person managing people's complaints is they very quickly know when they didn't get it. Or they know straight
Yeah.
away then that this was not what they wanted.
So, look, I think that honesty builds trust.
Yes, for sure.
And leads to better decision making for the patient and better decision making for the clinician, and to truly work in a partnership. And if someone is discouraged by that, I don't really see it as a loss.
I agree. So I have another question then about the social media. Do you think,
Mm.
sat where you're sat, that the perfect smile trends on social media have changed patients' expectations of what we can achieve and what they want? And then I guess the next thing is, I've seen some criticism about filters and influencers, about how it's contributing to dysmorphic thinking because it's creating, people are putting this, what is really an unattainable standard for most people, out there. And a lot of the time it is filtered and perfected. It's not actually real. And people are looking and thinking that's where they need to be. Are you seeing that social media is having a big impact? And
It is 100%. And also, not only with expectations about looks and things, like expectations about time,
oh
expectation
yeah,
how fast and how quickly things can be delivered. Um, I think that, I don't remember the year, but there was a study by the American Psychological Association, and I think that they reviewed 220 students and teens and young adults, and they've reduced for the group, the test group, they reduced their social media consumption by about 50% in a few weeks, for a few weeks. And then they compared them to the control group, and they just found that only for a few weeks of just reducing 50% of that social media interaction and access, um, the students felt improvements in how they felt about their weight, about their overall appearance, about all of those things, compared to their peers and compared to the people that had unvetted access to social media. So definitely those things are playing a role. And not only social media, I mean the media at large, but also unrealistic expectations about how long does it take to do things. And yeah,
no, it's sad. We can't even age in peace anymore, can we?
no.
So what do you wish then that patients understood before seeking cosmetic dental work? So many people, it just seems to be a really big market at the moment of people looking for this perfect smile. What do you wish they understood before they even embarked on the journey?
This is not only about dentistry and not only about smiles. Cosmetic treatment be more or less invasive, but particularly with the less invasive one. So is so ubiquitous that I think that there is a tendency for people to believe that is devoid of risks, is devoid of complications. And that's not true, obviously. Um, and the other thing is, I think overall, as a profession, we are very good at explaining the benefits of treatment to patients. Most of us, or the majority, I want to believe that we are good at explaining possible risk and complications. We are not very good at explaining how long the treatment is supposed to last, longevity.
What normal is for
I
that?
don't. I think that that is under discussed, and also the need for maintenance, care, and supervision, ongoing maintenance. I think particularly for artificial things like implants and things like that, and it's particularly with patients spend a significant amount of money, they have that expectation that it comes with a lifetime guarantee.
Yeah.
And that's not right. It's not correct. And usually things that are, the more complex they are, the more maintenance, ongoing maintenance they're going to need. So I think that we need to get better at discuss. So because we have patients and they come and it's like, oh, I want veneers. And if they're very young, you have to tell, well, this is the expected lifespan before you have to repeat this treatment because he will look age, because he will whatever. So I would like people to, professionals, but also patients, that the younger you are, the more towards minimally invasive we have to veer towards, and that things don't last forever, and that anything that is done now will have to be replaced at some point.
Sometimes more than once. And it is such a burden. And I think it's interesting as well when we talk about expectations. Like, for example, treatment in composite absolutely has a place, but after a period of time, it will start to look tatty. And
Yep.
that's okay as long as the
Yep.
patient knows that. And there are things that we can do to minimize or to make it not look tatty, delay that. But it's like you're entering into an agreement with the patient. It's not a case of, I'm going to give you this and you're going to go on your merry way and this is going to be perfect for the next
That's right.
20 years. There's things that they need to do and you need to explain that to them, and they need to really meaningfully understand what it means for them. I mean, this is something I've spoken about. I know you and I have spoken about this, but I talk about it on this podcast series all the time. I am terrified that there are people who've had some quite significant irreversible treatments done in their late 20s or early 30s who are going to have the shock of their lives in 10, 12 years time when it all has to be redone again. And I genuinely think it's going to be a huge shock to them. And it might have been in a 15-page consent form somewhere, but I
Mm-hmm.
don't think that they meaningfully embedded what that meant for them. And I do think that shock's going to be genuine. And I
Look,
really do.
you mentioned veneers, and there are many types of veneers and things like that. But most often than not, or more often than not, they require some tooth preparation, some tooth removal, and that is irreversible. And I have had patients coming and saying, "Well, I want veneers," and it's like, "Well, do you know that you will have to have some tooth removal and that you will have to replace them in, I don't know, 12, 15, 20 years, whatever that number is for you." Um, and a lot of people are not aware of that because they see, going back to social media, they see it in the social media, and that is not really in the social media. It's not explained there.
No, absolutely. And in some ways, nor should it be, because it's not necessarily the space for it. There is no substitute
Oh,
for that conversation, but there's no even indication. There's no even sniff of it. It's just all the
yeah,
good stuff without any of the bad. So,
that's right.
Carolina, what's one message then that you'd want our listeners to take away generally about beauty and self-worth?
um, well, as a woman rapidly approaching mid 40s, I have a lot to say about that.
Mate, 50 was when I turned 50, you suddenly go, wow, that's a big number.
I Look, I'm starting to enter that sweet space that I care and care less and less what people think about my appearance.
It's a beautiful time. I have to say, it's a beautiful
Uh,
time.
um, so, uh, yeah, this is a very philosophical question. Um, I would like to say that beauty is not fixed, it's not purely visual, and it's definitely not objective. I'm old enough to have seen the trends in the 80s and the 90s and the early 2000s and the 2010s, and they don't look like what we like in the 80s, looks nothing like what we like now.
It's true.
So it is certainly subjective. And I think that someone might have, let's say, perfect standardized beauty features and still come across as cold, performative, posy, arrogant, insecure. And suddenly you don't see them as beautiful
It's a really good point.
as much. And then you have other people that, they're conventional features, average, regular people, and they're caring and compassionate and funny and intelligent, and they care for you more than they can care for themselves. I'm obviously talking about my husband. And you see them as they have an irradiance of beauty about them. So I think that beauty without self-worth and without authenticity fades quickly. I don't know who said this, but I think about it a lot. I heard someone say that confidence is the ability to see yourself as a deeply flawed individual and still hold yourself in high regard. And I think a lot about that. And I also, again, as a middle-aged woman, would like younger people to know that what really brings sustainable happiness to life is the quality of your relationships and how compassionately you see yourself and others. And trends just come and go. Look, I don't want to, I didn't come here to talk badly about cosmetic treatment. It's something that I certainly do. I think that for the majority of patients, when they are well informed, they know what they want, and you seek a good outcome, they will be very happy. But it's all about patient selection.
Absolutely.
And yes, and delivering that care for the right people that will benefit the most, and just sway other people to other care that will benefit them more.
That's a really, really good point. It really is. And I have to say, I don't know, I quite like being a middle-aged woman. I think I was worried about getting here and I got here and I was like, this is awesome. I quite like it. I think there's actually a lot less pressure where I'm sat than it was when I was 20. But moving on from that, thank you so much for your time. It's been really good to speak with you. And I hope that our colleagues have taken a lot away from what you've said. So thank you all for listening.
Thank you
It-
so much. That
No,
was
it's,
great conversation.
no, it's been great to have you.